Hi, I'm Felix González. I'm from Emory University. I want to first thank the RSNA for allowing us to present our research based on the application of cold radiofrequency ablation for the treatment of shoulder and hip osteoarthritis. Osteoarthritis of the shoulder and hip is the leading cause of physical and mental disability globally. Arthritis and chronic joint symptoms affect 1 out of 3 adults, making it the most widespread disease in the United States. Conservative measures such as physical therapy and pain medications are often unable to completely address the associated chronic joint pain. While total joint arthroplasty is an established treatment for advanced osteoarthritis, a large subset of patients are not eligible due to other comorbidities and or costs. How big of a problem is osteoarthritis? Osteoarthritis affects approximately 30 million people in the United States, which is the most common form of arthritis. Approximately 10 million of those people have the advanced form of symptomatic osteoarthritis. Patients with OA typically suffer from chronic pain for approximately a decade. Up to 80% of these patients are not immediate candidates for surgical procedure or intervention to treat their chronic pain. And patients may suffer from other comorbidities or are undesiring of this surgery, which make them not optimal candidates for surgery. Chronic pain affects approximately 100 million Americans. Almost 2/3 of them believe that they will be in pain for the rest of their lives. The current treatment algorithm for symptomatic osteoarthritis involve non-invasive methodologies such as weight loss, NSAIDs, physical therapy, and intraarticular injections that contain anesthetics, steroid, or viscofluid supplementation. Approximately, patients spend about a decade suffering from knee pain or shoulder pain, and the majority of them, approximately 65% to be exact, do not have surgery for the treatment of their chronic pain. So one way to treat this pain is by disrupting the transmission of pain signals via neurolysis. So the pain associated with the joint, in this case, shoulder or knee, or shoulder or hip, does not reach the brain. This can be accomplished either by a standard radiofrequency ablation or what is also known as cooled radiofrequency ablation. A side note, cooled radiofrequency ablation is not the same as cryoablation. There's a difference between cooled radiofrequency ablation versus the standard form of radiofrequency ablation. In cooled radiofrequency ablation, usually there is an internally probe that leads to larger ablative lesions with temperatures that are less than 100 degrees Celsius, thereby compensating for the complex innervation that exists around the hip and shoulder joints. Cooled radiofrequency ablation has already been demonstrated to allow for sustained pain relief, improve function, and decrease dependence on pain medications in other joints such as the knee and sacroiliac joints for up to 2 years without significant adverse side effects. With COOLIEF or cooled radiofrequency ablation, the treatment zone is 5 times larger than compared to the standard form of radiofrequency ablation. So the protocol involves a lidocaine or anesthetic nerve block prior to the ablation procedure. Usually 22 gauge 3.5-inch spinal needles are utilized. They are advanced under direct image guidance into their respective locations around the hip or shoulder pains when these sensory nerves are located. And a positive response is when at least 50% of pain reduction is achieved. Then the patient is allowed to proceed with the ablation procedure, usually scheduled between 2 and 3 weeks afterwards. The device includes a water pump, a generator, introducers and pumps, and the probe. Usually moderate sedation is utilized and supplemented with nasal cannula oxygen administration. Local anesthesia is provided by 1% lidocaine within the skin and the immediately adjacent subcutaneous soft tissues. Then an introducer, which can vary between 50 and 150 millimeters in length, 17 gauge in size, is placed at the target anatomic locations to then treat the respective nerves. This is accomplished by applying a frequency for approximately 2.5 minutes to achieve a target temperature of approximately 60 degrees Celsius. Prior to the ablation, motor neuron activity is excluded by activating the site at 2 hertz, utilizing a 1 milliamperes of currency. And upon subsequent absence of motor muscular contraction, and then the ablation is proceeded with. Shoulder, in the case of the shoulders, there are 5 different ablation targets that are treated. On the posteriorly, 2 locations are targeted. The location of the upper 1/3 of the glenoid rim, approximately 1 to 3 millimeters away from the joint line. And then, so that's one location, and then approximately 1 millimeter more inferiorly is with the second target. And then we proceed to target the axillary nerve at the base of the greater tuberosity. And again, 2 locations, 2 sites are ablated 1 millimeters apart from each other. And then the patient is turned around completely from a prone to a supine position. And the third nerve that is treated is the lateral pectoral nerve at the midpoint of the coracoid process. These are the respective nerves that are treated, the suprascapular nerve. Here you can see the probe at the upper 1/3 margin of the glenoid rim, targeting the sensory branch of the suprascapular nerve, approximately 1 to 3 millimeters away from the joint line. And then the needle is directed more inferiorly, approximately 1 millimeter, and the second ablation zone is accomplished. Then the patient is turned on the lateral oblique side position, and the base of the greater tuberosity is targeted. In this location, the axillary nerve is the target nerve, which is basically illustrated here within the red box. Here's the second site, approximately 1 millimeter more distally. You can see it here. Then the patient is asked to turn around, and the lateral pectoral nerve at the midpoint of the coracoid process is targeted, as illustrated here. And you can one key point here is that we want to rotate the C arm approximately 15 degrees in an oblique position to project the coracoid process in a thumbs down configuration or appearance as you see it here. So we want to go from here to here, and then in this position target the lateral pectoral nerve at the midpoint of that coracoid exposed thumb down coracoid process. In the case of the hip, 2 targeted nerve positions are aimed. So the first one is at 12 o'clock at the acetabular dome, and here we aim for the femoral sensory nerve, and more inferiorly at the level of the incensura, the abdominal nerve is targeted. And you can see inframedially that 2 sites are usually done, 1 millimeter away from each other, one of them more proximally, the other one more distally or inferiorly. And this is to target the respective nerve, right? You can see here the femoral sensory branch of the femoral nerve and the abdominal nerve. And basically by targeting these 2 different nerves, most of the anterior shoulder hip pain is treated, which is believed that the pain is mostly coming from the anterior aspect of the joint. So again, these are the two different sites in the case of the hip, the femoral nerve at approximately 12 o'clock, and the aturde nerve at the level of the insensura of the acetabulum. One caution here is that the hip neurovascular anatomy is quite complex, as you can appreciate here. And the access point, we first have to, on the ultrasound surveillance, trace all the pertinent and important structures, such as the inguinal ligament, the femoral crease, and the location of the femoral artery. And usually the access point is inframedial to the location of the femoral artery. We will basically utilize that as the entry site. And then the hope is that we will land or place a needle at the level of the ischial tuberosity and slowly advance the needle all the way up to the insensura, as you can see there. Here, the tip of the needle is at the base of the insensura, and in this location, we do two different burns. We do one immediately inferior to the insensura, and then we retract the needle approximately 1 centimeter more distally, and we perform the second ablation site here. And this is sort of the RF probe pathway. So we first, touch down at the ischial tuberosity and slowly advance the needle all the way up to the base of the insensura. This is the location of the femoral nerve treatment site at approximately 12 o'clock at the mid-acetabular dome region. And again, in conclusion, we are proposing a new novel technique targeting the nerve surrounding the shoulder, in this case posteriorly the suprascapular nerve, the axillary nerve, and then anteriorly the lateral pectoral nerve. And we specifically target the sensory branches of this respective nerve. And in the case of the hip, we target anteriorly the femoral nerve and the aturde nerve as a way to treat moderate to severe arthritic pain. And lastly, we would like to introduce preliminary data out of a pilot study at our institution. We tested this technology on 12 patients with shoulder pain in the setting of moderate to severe osteoarthritis. We follow up with the patients at 3 months after the original ablation procedure by asking them to complete a clinical validated survey, and we observed approximately 83% pain reduction and a 74% overall improvement. We also applied the same technology on 11 hip patients in the setting of moderate to severe osteoarthritis, and there, in this setting, we observed approximately 70% pain reduction and a 66% overall improvement. We think that we're only scratching the surface with this technology, and we would like to further advance it by applying it in other areas such as oncologic metastatic disease. We thank you for your attention. We wish you a happy meeting, and thanks. We would like to officially thank the RSNA for this opportunity. Stay safe. Have a great day.